Hi, it's Dr. Centeno, and welcome to You've Got the Power. Got an interesting topic today. We're going to talk about the transverse occipital ligament and what that has to do with craniocervical instability, or CCI. This is an interesting one because it's a ligament that doesn't get talked about a lot. There are a couple of these ligaments, like the accessory atlantoaxial ligament, Barco's ligament, and others that never really seem to get mentioned when CCI is talked about. You know, the big ones often get mentioned: alar ligament, transverse ligament, supraspinous, interspinous ligament. But some of these other ligaments are also interesting in what they do. But again, no one talks about them. So we're going to go through some of these ligaments. Obviously, I choose different topics on different days. Today, we'll get into some of these ligaments that you hear less about. We'll also be talking up and coming about the vagus nerve and headaches. So lots of interesting things coming up, but I'd like to touch on some of these ligaments that you just don't hear as much about. So again, for those of you that are just joining us right now, we're talking about the transverse occipital ligament, what that is, what it has to do with CCI, what type of CCI are we talking about, and getting into some of these other ligaments that are just less discussed than things like alar and transverse ligament. So we'll get started with that, and then obviously you can ask questions on that topic. You can ask questions on any other topic you would like. Goal is to get everyone's questions answered. So try to get those questions in early. I'm going to go for about an hour today, and obviously I'll get to as many questions as I possibly can, but it always seems like we have more questions than time. So try to get those in as early as you can. So let me go ahead and share my screen here, and we will get started talking about the transverse occipital ligament and what it is and why it is important. Okay, so the transverse occipital ligament, you should be seeing that on your screen now. So this is a really interesting view that I have here as the background, and I'm going to show you this in more detail, but it just shows you the complexity of the upper cervical ligaments. So we'll get into what that view is. So again, if you're interested in getting evaluated to see if you have CCI, or if you're a candidate for PICL or any of the other procedures we perform in the upper cervical spine, C0, C1 facets, 1, 2, posterior ligaments, etc. Our call center is very, very focused on lots of different things: shoulders, ankles, knees, backs, etc. And I really find that many of our patients obviously have much more imaging than the average knee patient does, and that stuff is very complex. So it's really better to send an email to my assistant if you're interested in getting on the schedule for those things, just because she is much more attuned to what CCI patients need. So this is the reference for today. So this is, I think, a super interesting view. So this is looking from the spinal canal. So if you could put yourself in the spinal canal where the spinal cord lives, and if you were looking forward, this is what you would see. Now, there'd be dura over this, so you'd have to have x-ray vision to see all of this, but this is where the dens is here. So I'm marking where the dens would be, so you get a sense of that. So you can see that transverse ligament is acting as a seatbelt for that dens. And I'm just trying to do little dots here. Hopefully this works. And that you can see the little dots. But that's the dens and where that goes. So as you can see, if we look at all of these different ligaments, the transverse ligament acts as a seat belt for the dens. So if the dens is a person, the transverse ligament is acting as a seat belt, preventing that dens from coming into the spinal canal. and this is C2 down there, and the dens, I'll mark, well, it's behind everything you're looking at there. Then we've got the alar ligaments that come up almost like arms from the dens, and they go up to the skull. And in fact, there's a lower alar ligament part here that's really never shown, but it kind of goes down like that. But we see it all the time when we do these procedures. And then you've got Barkow's ligament way back here, which we've never talked about, but we will here in the future. And then you've got this thing over here called the transverse occipital ligament that is also in front of the dens. So the transverse ligament is basically like the seatbelt for the dens. So if I had a seatbelt on down here, but this transverse occipital ligament is kind of up here. So it's a piece of tape or duct tape going back this way. So as you can see, both the transverse ligament and the transverse occipital ligament are there to prevent the dens from going backwards towards the spinal cord. So in anyone who has problems where the dens is going back towards the spinal cord or the medulla, or what we call cervical medullary syndrome, you're going to have laxity of this transverse ligament and laxity of this transverse occipital ligament. And this is just my own drawing here. Let's go back there. And actually, I drew this morning early. So if we go like this, and that's the ligament there, this is going to be that transverse occipital ligament. So this transverse occipital ligament is going to be coming across the top of the dens. So again, a piece of duct tape across the head, if you will, if the dens is represented as a person. And the arms of that person are going to be that alar ligament, which comes like this and then goes up towards the skull. So again, there's a lower portion of this alar ligament, then it comes up like this and goes up towards the skull. There's an upper sling portion of that alar ligament, which is rarely talked about, which probably is also mixed in with Barkow's ligament there. And then we've got the transverse ligament, which is acting or going across like this and acting as a seat belt for that dens. So the transverse occipital ligament, piece of duct tape up here, the transverse ligament, which I'm going to put a T here for the transverse ligament, acting as a seatbelt for the dens. So what does that ligament do? Now, remember, this is a side view now. So this is going to be the transverse occipital ligament. We'll call it the TOL here. And realize that the transverse ligament is going to be down here. Again, this is a side view now. So if the transverse ligament is down there, we'll call that TL. So again, as you can see, if C2 wants to come back that way, there's going to be two things that prevent it. And actually, there's going to be another thing as well there that's not even drawn in here. And that's going to be the tectorial membrane. Tectorial membrane is going to come around like this and then become confluent and eventually become the posterior longitudinal ligament down here, PLL. But the two big ligaments that are going to prevent that dens from going backwards towards the spinal cord and medulla are going to be that transverse occipital ligament and the transverse ligament. Remember here that, I can draw in now the spinal cord and medulla there. And as I draw in the spinal cord and medulla, so this is going to be the spinal cord here, medulla up there. That's where we get into cervical medullary syndrome. So C2 coming back towards that spinal cord and medulla can cause a cervical medullary syndrome, and that's going to be pressure on that area. So it's both of these ligaments, the transverse occipital ligament and the transverse ligament that are going to be a problem in those kinds of patients. So if we look at the grading system that I often talk about and what kind of thing we're discussing there, that's going to be C2 going backwards, and that's a separate type of instability, usually cited as due to that transverse ligament. But there's going to be another thing that can happen here too, because that transverse occipital ligament connects into the skull and not C1. Remember, this transverse ligament here is linked into C1. So I'm going to draw in C1 there. But this transverse occipital ligament is linked into the skull. So since it's linked into the skull, it also limits the posterior rotation of the skull and extension. So if the skull wanted to do that, it would be this transverse occipital ligament that prevents it from moving in that direction. So we have two things now then that this transverse occipital ligament does. One is it prevents C2 from going backwards into the spinal cord and medulla. The second is that it limits skull posterior rotation and extension. And there are going to be other ligaments that are at play here. So if we're talking about resisting skull rotation and extension, that's going to be also the superficial atlanto-occipital ligament up front here, which is just an extension of the anterior and longitudinal ligament, the AAOM, the apical ligament. All of those things are going to prevent that same posterior rotation of the skull. Now, when it comes to what else prevents C2 from going back like this, that's going to be, as we talked about, that's going to be the transverse ligament down here. I'm going to draw it in there. And that's going to be this transverse occipital ligament over here. So this is going to be, again, transverse occipital ligament. And this is going to be transverse ligament down here. So again, those are two different things that we're discussing. Now, this can impact patients with different kinds of CCI. One type of CCI it would really fit with would be type 1B, and we'll talk a little bit about that. But also the type of instability or a type 2A, where that dens comes backwards, would also be something else to discuss here. So that type 1B, just to remind you, is when the skull rotates back like that and the lax ligaments are up front, and we see an increased clivo-axial angle. So realize that that's one type of instability that would be important here, and that would need to be treated from the front with that PICL procedure. If we're talking instead of a type 2 instability where C2 is going back that way, then, and that's again going to be the transverse ligament down here, transverse occipital ligament up here, then same thing, we're going to have to hit that from the anterior. So what kind of injections are we talking about? We're really discussing those 5-star injections where we can do the anterior approach and get to those ligaments. And again, just to wrap this up and just to discuss that the transverse occipital ligament has an important function in not only stabilizing the skull, but also stabilizing the dens of C2 and preventing it from going backward. Now, again, if you're interested in being evaluated, please reach out to Carla Salas. I wouldn't fill out a form on the website or go through the call center, just because I think you'll get much more expeditious service if you reach out directly to Carla. And this is Carla's email address right here. So let's go to questions and see what kind of questions we have for today. Okay, we got lots of questions. Andy, are the alar transverse ligaments more strong or harder to sprain than the posterior ligaments? The transverse ligament in particular is considered one of the strongest ligaments in the body. I've seen various reports on that, everything from the strongest ligament to the body or in the body to one of the strongest. So the transverse ligament is the king, so to speak. And that makes sense, right? Because it holds that dens back so it doesn't go into your spinal cord. If that dens goes into your spinal cord in a big way, not the kind of things we see in some of the CCI patients I treat, but if it really goes completely back into the spinal cord and crushes it, that's not compatible with life. That's how a hangman's fracture, for example, would work. So transverse ligament, strongest ligament in the body. Alar ligament is another very strong ligament. So these ligaments are much stronger than the posterior ligaments. Darian, Dr. Centeno, can stem cells regenerate cartilage? In very limited specific situations, we have seen evidence of that. Is there good evidence that in all circumstances stem cells regenerate cartilage? No. So that's generally not how they would work in someone's knee who has severe osteoarthritis, for example. And if you're hearing that they do, then that's just made up stuff. Andy, can weakness in the deep neck flexors cause balance issues and a feeling of a bobblehead? So let's talk about that for a second. So the deep neck flexors are deep in here, longus colli and longus capitis. Their function, important function, would be as you bring your head back, they're going to control that motion and allow the vertebra to form a curve. Now, when you go, if you're laying down and you want to get up, they're also going to be important because as you flex your neck and getting up, they're going to start that flexion between the vertebra, and then these sternocleidomastoids are going to kick in and take over. So if you've got weakness in the deep neck flexors, can you feel like a bobblehead? You can. But bobblehead sensation also comes from atrophy of these upper cervical muscles, which are quite plentiful way back there. Arno, can CCI, jugular vein compression, cause high blood pressure? I've always had normal low, but now I've isolated systolic hypertension. Usually not. You just need to realize that what can cause high blood pressure is inactivity and metabolic syndrome. So what is metabolic syndrome? Metabolic syndrome is when you start to put on weight and you aren't very active. You get high triglycerides, high blood pressure, etc. Usually insulin resistance as well. In addition, for many patients in chronic pain, Tylenol can increase blood pressure. So if you are taking Tylenol, you can experience elevated blood pressure just from the Tylenol, or if you're taking pain medications that have Tylenol in them. So that would be more common than something like internal jugular vein compression leading to high blood pressure. Regenetics been advanced by DB or issues with ligament, something you would show up on an MRI. With this ligament, no, regrettably, this ligament is rarely seen even on the highest field MRIs. So what we would see is the functional changes on MRI that can be associated if this ligament is injured. So for example, we might see a high grab oaks because that dens has gone back towards the spinal cord. Or on flexion extension MRI, we might see that as the person flexes, that dens moves further back. In order for that dens to move back, in 80% of the patients that have this ligament has to be stretchy as well, in addition to the transverse ligament. Ricky, neurologically, what symptoms can be affected by CCI? Lots and lots of symptoms. I've got a whole thing on that. So let's go and pull up those common symptoms. We'll look at that. Okay, let me share my screen again here. So as you can see, lots of symptoms associated with CCI. As far as quote neurologic, that's sort of a term for me that's all over the place. It should mean any symptom that is caused by or facilitated through the neurologic symptom, but that's all of these. So that doesn't make much sense. I think as most patients use it, it seems to be in patients' direct discussions back and forth. It seems to be those symptoms that are more autonomic. So if we focus on those, that would be things like brain fog, excessive sweating, nausea, POTS symptoms, blurry vision, tinnitus, those sorts of things. And this is 101 CCI patients. So the bigger the word, the more common the symptom. The smaller the word, the less common the symptom. So that gives you some idea of all the different symptoms that can be caused by CCI in confirmed patients. Okay. It's been advanced by DB. Would love to come see you, but I am in Ethiopia. Do you have anyone in my general area that could help at all with these issues? No, definitely don't know anyone in Ethiopia. Hard enough to find someone in the US that has any idea. So Rabbi, I can't help you there. Robert, many I speak with prefer a slight lift of the skull. They actually lift up with front teeth and back of head. It's a type of settling. How is this correct? Being a gravity affecting type issue, or is only a multi-muscle spasms pulling too hard? So Robert, I think what you're saying is go like that and pull the skull up. It probably has, in vast majority of patients, nothing to do with cranial settling, because that maneuver would offload lots of painful things. So if you're 0-1 and 1-2 or 2-3 facet joints were pissed off, that'll offload those and make those feel better. If certain spinal nerves are impacted in the upper cervical spine, those will offload those and make that feel better. So, and then there's a small percentage of patients who will have true cranial settling. Realize that from a neurosurgical standpoint, cranial settling is if you've got the big hole in the bottom of the skull called the foramen magnum, the dens is actually up into that hole. That's the definition, at least the neurologic definition of cranial settling. So there's very few patients I see or evaluated for CCI that meet that definition. Then there's a much softer definition, I think, of when there's a smaller BDI and or measurement between the dens and the basion, basically the dens in the skull, and the skull is low-ish relative to the dens. But cranial settling from a neurosurgical standpoint, remember, is when that dens is into the hole at the bottom of the skull or the foramen magnum, and not many CCI patients I've evaluated meet that criteria. Darian, why do other doctors claim PRP does nothing, including tightening of ligaments? Don't know, Darian. At this point, PRP is becoming more and more widespread in its use. We've got about 3 dozen randomized controlled trials for different types of orthopedic applications, everything from knee arthritis to tennis elbow to carpal tunnel syndrome and other things. I think what you're hearing is mostly a doctor who hasn't kept up with the peer-reviewed literature. So they're just not keeping up. Now, it's hard to do these days because even in orthopedic and spine surgery conferences, there's usually talks now on PRP. So you'd have to not only read the literature that's being published, but probably skip those lectures or maybe not go to the annual meeting. I'm not quite sure why. Bethany, higher Centeno, is it okay to start physical therapy and curve correction 3 months after first PICL? Would alar ligaments be strong enough for that to handle traction using Dinerol? I think you would have to be careful. 3 to 4 months is probably ideal for that. So you could cautiously proceed with little bits at around 3 months, trying to do a little bit more aggressive things at 4 months. Eugenics, it's been advanced by Sherry Kopp. Why don't spine specialists know all the things you speak about? I've seen 6, none of them have ever even mentioned CCI, let alone all the specific ligaments you speak of. Yeah, it's like anything else. It's area of expertise, right? So let's take an example. Let's say a patient walks into my clinic and they've got some rare form of lumbar cancer or a tumor kind of in that area. Now, I'm not an oncologist. Certainly, if the radiologist calls it on the MRI, then I would certainly say, hey, you've got to get this tumor checked out. But I look at MRIs from the standpoint of the neuromusculoskeletal system. So I may or may not see that tumor there. And I certainly wouldn't know which, off the top of my head, which types of tumors would be common in that spot. Let's say it's at a spot just anterior to L5. Now, an oncologist that deals with that all day would be able to rattle off the 3 most common types of tumors you'd expect to find there, what their treatments were, et cetera, what the likelihood of needing to have surgery would be to remove the tumor, and probably talk about 4 or 5 randomized controlled trials as well. So expertise matters in medicine. So if you're seeing a general spine surgeon, that general spine surgeon probably has never even treated a CCI patient. Maybe in a large university medical center in their residency or fellowship, they might have seen a few come through the ER where their head was hanging off and they needed emergency upper cervical fusion, but that's the closest they've ever gotten to it. So they're not looking at these films in the same way. They couldn't tell you who Shane Tubbs is. He's the guy that published that article, has published many of these articles on these lesser known ligaments in the upper cervical spine. Certainly couldn't recite the randomized controlled trials on PRP, et cetera. So it's just all areas of expertise, in the same way that I'm not going to be an expert on the fine differences between an open door laminoplasty and a laminotomy versus a partial laminectomy. I could tell you what those are. I could tell you what my personal opinions are and the stuff I've seen for patients who have had those. But as far as the finer surgical details of how much time those take to perform in the OR, I'd be lost on that question. So it's just matching expertise with a problem. Stacy, so does injecting TOL help with a retroflexed odontoid? Only if let's make sure that people understand what that question is about. So the odontoid is C2. It's the dens from dental, meaning the Latin is tooth. So the odontoid looks like a tooth-like process that comes up from C2. So the odontoid comes up. Now, that odontoid, if this is where the spinal cord is, can be backwards. And that's called a retroflexed odontoid. Now, some people are born like that. So there's nothing that's going to change if we inject the transverse occipital ligament. Other people have retroflexion, meaning the odontoid goes backwards because of those loose ligaments. So that certainly might help an odontoid from going further into the spinal cord with someone flexing their neck. And then some people have a retroflexed odontoid because of dramatic changes in the shape of the spine. And so this may or may not help that. You'd have to treat the whole spine to get there. Manuela, I just did the detailed MRI with Scott Rose, and he noticed that when I extend my neck, my myodural bridge folds. Should this fold while flex and extend? Could this be a cause of my skull base pain? If not resolved after 2 PICLs? So Manuela, I don't know you as a patient, but let's go backwards here to your question. So the function of the myodural bridge is to pull the dura out of the way when your head extends. So so if it doesn't work, the rectus capitis posterior minor muscle that's jacked into that connection between the muscle and the dura may not be functioning correctly. So there's a couple different ways to deal with that. One way would be to inject the myodural bridge directly, because sometimes muscles don't work just because of tendinopathy, meaning the tendon is sort of chronically pissed off. Now, another thing to consider would be ligaments like the ones we're talking about today. For example, remember we talked about that rotating your skull backwards. This transverse occipital ligament would be important in that motion. So that's another thing to consider. But if you've got infolding of the dura when you bring your head back, that could be the rectus capitis posterior minor tendon as it attaches to the myodural bridge. So that would be a potential injection target. Robert, perhaps I missed it. I don't see the transverse occipital ligament, a number of anatomy. Yeah, so it's not going to be in those. I looked myself for Elsevier's complete anatomy, which I think used to be 3D Medical, but I think they got bought by Elsevier, which is a big publisher. Not in there. My guess is it's in the slices, because meaning those things were created from a cadaver project way back when. I think it was in the late 90s, early 2000s. But many of those things were just not digitized, simply because maybe they didn't know what it was, or they didn't have a slice through it, et cetera, et cetera. So I wouldn't use complete anatomy as a upper cervical guide, because if you look at some of the publications by Tubbs et al., which is the guy we're talking about that published this paper, they've got all sorts of ligaments they've identified in 80 or 90% of the specimens they looked at that aren't in complete anatomy at all. In fact, even if we look at the alar ligament, that's not accurate, because as we inject it in people, it's got a lower part and then an upper sling part that doesn't show up in any of the illustrations. Now, why do these things sometimes not show up? Simply because if you've ever done dissection like we're required to do as physicians in our first semester of medical school, it's pretty brutal, meaning that in order to get stuff apart and get stuff exposed, you're frequently destroying things you didn't really intend to destroy. Now, some of the more experienced anatomists that do that all day, every day are better at not destroying things. But heck, we're still seeing ligaments and lymphatic networks and other things being published on that we thought didn't exist 10 years ago. So for instance, the anterolongitudinal, or the anterolateral ligament in the knee was only discovered 10 years ago, and that's a knee ligament. So yeah, regrettably, complete anatomy misses a lot of that stuff. Stacy, have you always injected the TOL during PICL, or is it new? We certainly always injected in that upper area. As far as being able to identify the TOL distinctly, that's going to be new. So that's something that, remember, we just started going above the atlas with any frequency about 2 years ago. And so this will be a new target to try to differentiate from the upper alar sling based on where it's going. So we'll have to see how that goes. It's a relatively new ligament. Again, not new, it's been there. It just has not been described. Regenix, it's been advanced by Harry Winston. Can issues with the transverse occipital ligament cause any issues other than CCI? No, this would be mostly CCI type things or cervical medullary syndrome, as we were talking about before. Arno, if there is CCI but not severe enough to compress the spinal cord, how can it cause any symptoms? How else does the instability affect symptoms? Yeah, Arno, if you read the book I've got out there, that would be a good one because it'll talk all about how many of those symptoms get generated. So let's just talk about one in particular that's relatively common. Well, actually, we'll talk about two: headache and dizziness. Those are the two most common. Headache is going to happen in many patients because the 0-1 and 1-2 facet joints get beat up by the instability. Then they get pain themselves and they refer pain to the head. Also can happen because of the muscle tightness up here due to the instability, and there are nerves that snake through those muscles, leading to, again, pain in the head, or the dizziness due to abnormal position sense information from those same upper cervical joints. So lots of different ways for lots of different symptoms. Robert, then is the V sign of the 8i space, is this more TOL? Yeah, Robert, that's a really good insight, because the answer is yes. And let me see if I can go back to the presentation for a second so we can look at that, because I think that's definitely something we'd want to explore just for a second. So let me go share my screen here. And we're going to go from this slide here. And I'm going to get a pen again. Okay, so very good insight, Robert. So what Robert's talking about is this space, ADI, between the back of C1 and the front of the dens is the atlantodental interspace, or ADI. Now, in some patients, that can open in a big way, but in patients who don't have major opening of this atlantodental interspace, again, the space between the dens and the atlas, often when they flex forward, what they'll have instead is sort of a V-shaped ADI. So in that case, I'll see if I can draw it. Pretty hard to do with the mouse, but I'll give it a shot. If that's the dens, and this is the atlas, the atlas tends, so this would be C1, obviously C2 here. They tend to get this V shape between the two. And I think, as Robert has astutely pointed out, that would be due to laxity in this transverse occipital ligament, because the transverse ligament is still working down here. And so that's the seatbelt of the dens, but this part of the dens has been able to go backwards due to a lax transverse occipital ligament. So that would be called a V-shaped ADI. So very astute observation there, Robert. So the answer would be yes, and that should have made it into this presentation. But when I'm working on this at 4 or 5 in the morning, sometimes I don't think about all that. But yes, very astute. V-shaped ADI would be due to laxity in the transverse occipital ligament. Hope you guys understood what I just did there. So I'm going to get rid of that, and we will go back to where we were. Arno, the extension case you showed last live where C2 bumps out during extension seems severe but doesn't actually present the spinal cord. So how would that cause symptoms? Let's see. I think the one that you're talking about is the one I presented on Friday. And so in that case, the skull was sliding backwards relative to the atlas. So first thing on symptoms there is we saw, I think it was the left, but I'm not 100% sure. But let's say the left C0, C1 joint was filled with fluid. The guy had left-sided headaches. So that's going to be due to swelling in the left 0-1 joint, causing pain in the back of the left head. So that's one of the reasons he would have symptoms. Obviously, with that upper cervical instability, he's going to get the back of the spinal cord banged into, so that can lead to symptoms. might lead to pain in various parts of the body. For instance, that's where the dorsal columns of the spinal cord live, et cetera, et cetera. So those are all different ways that would lead to symptoms. Bethany, if I have a swollen bursa between the skull and C1, would that indicate a damaged TOL? Doesn't necessarily mean a damaged TOL. It might be any motion of the dens or C2 related to C1. So for example, if C1 was moving around too much, that might cause that, because that's going to bang into the front bursa between the atlas and the dens. Or if C2 is banging around too much, meaning at C1, C2 instability, then that can cause both bursas to get in on the act. Finn, do all Regenetics providers follow your recommendation levels of treatment? For example, will London provider use contrast pre-injection C0? Not sure what you, as far as, again, as I've said before, the knowledge base on upper cervical isn't in our provider network. So if we're talking about an upper cervical injury issue or craniocervical instability, that's Colorado only. Now, I don't know what the second statement means here. For example, would a London provider use contrast pre-injection for C0? I think what you're saying there is maybe a C0, C1 facet injection. And would a London provider use contrast for that? The answer would be yes. But then we get into what we've discussed before, and that is that you have to have ongoing experience in doing those, or do several hundred of those cases a year. And then you've got to use digital subtraction angiography. So I don't know the answers to those questions, but as far as using contrast, yes. Ron, on my DMX report, C1, C2 lateral bending of mouth with rotation, 11.6 millimeters left, 8.9 right, C1 uncovers 62% of the C1 facet. Yeah, so if we're talking about a DMX and facet uncovering, that's not something that's been studied, so I have no idea what that means when it comes to instability. Now, if you're talking about, I think the measurements that you're talking about here on C1, C2 lateral bending have to do with the position of the dens within the atlas. And those aren't the numbers we look at, although those numbers are important for determining asymmetry. So that's the first part of looking at overhang. The second part of looking at overhang would be what the corners are telling us, meaning the C1 overhang in the C2 corner, and what distance that is. So in order to answer a question, I'd need to know that information. But as far as if we're talking about a DMX that shows that 60% of the C2 facet is uncovered, that's not part of the Katz Freeman study. So is that normal, not normal? I don't think anyone knows. Arno, regarding the high blood pressure question, I have a BMI of 19 and bike at least 30 minutes a day, no insulin resistance, checked A1C, no medication, yet high blood pressure, which started right after neck injury. So the next question, Arno, would be what's happening with Tylenol usage, and could that be causing high blood pressure? That's one possibility. Obviously, it may be possible to change blood pressure through a vagus nerve issue, so that's another thing to possibly investigate. Darian, do you see any new orthobiologic injection breakthroughs in the near future? I think the biggest things we'll see over the next 5 years would be various culture expanded cells getting approval through FDA. That'll be a big breakthrough. Right now, we've got to take patients down to Grand Cayman, for instance, to get that done. So the ability to do stuff like that in the United States is probably next on the list. WW Soft, how many weeks out do PICLs schedule after initial consult? You know, that's a question for Carla, my assistant. She would know that answer. So I'm going to put her email down here. So I'm just putting her email in the comments so that you can go ahead and reach out to her on that one. She'll be able to tell you there. Rhymes. Hi, Centeno. After a few rounds of PRP injection, I'm feeling better now, but I do still have some symptoms like imbalance, itches, etc. There's a trigger point on C23. Can it be injected laterally? Not sure what you mean there. Can it be injected laterally? So if we just talk about imbalance, that can be due to the C23 facet joint. That can be injected posterior or lateral with X-ray guidance with contrast. So I need to know a little bit more there. Isabella, can prolotherapy in the occipital ridge loosen the muscles in the neck or damage nerves, veins, or arteries? I've had a severe increase in tinnitus from it. Can it still heal? It was 3 months ago. Yeah, Isabella, I think we've talked about this before. If we're talking about blind prolotherapy, or even prolotherapy done inexpertly with ultrasound, the answer is yes, you can damage nerves, veins, and arteries. That's why we don't do it that way. We would only use X-ray guidance with contrast to make sure we're not in veins or arteries, for example, and other precautions like digital subtraction angiography. If you got something injured like that, can it still heal? It would really depend on what was injured, so I would need to know more. Stacy, I've had a conflicting diagnosis, different DMX doctors enter this thesis of 4-5 versus retrolisthesis, C6, or lay flat with rolled talus neck, I get severe vertigo. Yeah, Stacy, so if there's still upper cervical instability, then that can cause increased vertigo. It'd be unlikely that either the enterolisthesis at 4-5 or C6 is causing that. Now, I guess it's certainly possible that something else happens in that position. So you could do, it wouldn't even take a DMX, just a lateral fluoroscopy view with a towel rolled up in that position and see if there's any abnormal movement of the bones, i.e. if you had severe subluxation of a bone forward or backwards, that could impact the vertebral artery, etc. But more likely than not, it's still some upper cervical instability that would cause that, because as I've often said here, a lot of patients really aren't ready to do curve restoration because they're still unstable in their upper cervical spine. Scott, thank you for these videos. Is it possible for some cases of CCI to be fully resolved with PT, curve correction, or can ligaments only realign original tightness via PRP, Prolo, PICL, etc.? No, Scott, certainly possible, especially in the acute phase or subacute phase, for physical therapy, curve correction to allow these ligaments to heal. So we've seen, for instance, Dr. Katz, I think, just published a nice little case series on some patients he treated with curve restoration that were in that subacute, meaning, let's say, 3 to 6 months out after a car crash, where he was able to get the curve back, and then they healed and they showed much better DMX results. So listen, the goal is always to get that stuff to work first. So again, I would always encourage patients to do those things, those conservative things like NUCA, for example, like curve restoration, like physical therapy, well before they see us. Now, the vast majority of our patients can't tolerate that, or they get temporary relief with NUCA or AO, chiropractic. But it's definitely something to do first before you see us. Darian, what exactly makes stem cells superior to PRP in most cases? Well, they're not really superior to PRP in most cases. It depends on the application and what it is we're treating. So, for example, for a irritated tendon or tendinopathy, PRP works great. There really isn't any advantage to using stem cells. Now, if we have instead a tendon or a ligament that is more ripped up, then you're going to see an advantage. And why is there an advantage? Because stem cells or bone marrow concentrate would have both growth factors and cells that can differentiate into tendon or ligament cells, whereas PRP just sort of ramps up the existing repair response. Okay, Rhonda. If there has been no neck trauma, is Lyme disease possible cause for alar ligament laxity? I don't see any evidence that that's the case. I think I reviewed that, probably 8, 9 months ago with a video. And I looked at, there's only one small study, I think it was out of Germany, maybe Switzerland, that seemed to look at that, but the pretty poor methods in the study, meaning that we didn't know if the guy who had looked at that had sort of taken a bunch of people who had CCI for various other reasons, because that wasn't controlled for, and then blamed it on Lyme's disease. There was no accepted standard on who had Lyme disease, who didn't have Lyme's disease, etc. We didn't know what the percentage of Lyme positive was in this portion of the world, et cetera, et cetera. So there isn't really good research to show that that happens. Now, listen, I've been in medicine long enough to know that all sorts of things come down the pike that we didn't think were could be related, like vagus nerve disease and inflammatory arthritis. 10 years ago, there was no relationship between the two. Now that there's money in it for device manufacturers to make vagal nerve stimulators, it's a thing. The research has gotten much better. So we may certainly find out one day that Lyme disease is associated with ligament injury in the upper cervical spine. But right now, we really don't have data to tie those two things together. Stacy, if you confirmed I have CCI, would the stretching decompression aspect of the CBP be something to avoid? Well, again, if patients have CCI, an awful lot of our patients can't tolerate curve restoration. Now, some of them can, and obviously we would encourage those patients to try curve restoration. But as far as existing CCI patients, we wouldn't generally tell them to try something like that unless we had solved their CCI through injection. And we're always going to be asking people to carefully experiment, right? Putting a rolled up towel and lying face up on it is worth seeing if you can tolerate it, because if you can tolerate that, you might be able to tolerate seeing a curve correction provider. Mark, for specific whiplash trauma, what is your definition of baked in time frame from accident date? I mean, there's no hard and fast rule, Mark, but I would say that as the years go on, the risk of baked in neurologic changes goes up. So I think, as I've said before, we probably have about half of our patients who have had this for a very long time, who have baked in neurologic changes, meaning nothing we're going to do are going to change certain symptoms, because that neurologic damage ship has sailed. The other half we can help, who have had this for many, many, many years. So it's really pretty unique to the person. Why? Probably based on trauma to various areas, other health issues that might make the nerves weaker in some patients versus others, genetic issues, et cetera, et cetera. S. Dennis, I had PRP and Prolo done to above C3 and it helped my CCI tremendously. Great. Let me know if there's a question in there. Happy to answer it. Robert, hypothetical question. If stem cells are injected in a healthy area, can a negative effect happen? Not that we have seen. No, I've been studying this and complications since 2005 and published, I think, still the world's largest orthopedic stem cell complications paper. So we don't see any evidence of that at this point. Finn, is there data on the optimal interval between rounds of Prolo? Presumably it's a balance between keeping the healing momentum and leaving time for ECM deposition. Yeah, Finn, I think you want to leave some time for the process to complete, at least the acute inflammatory process. So acute inflammation lasts different amounts of time in different people. So for example, if you had a young, healthy 20-some-year-old and you were doing Prolo, they're probably going to complete their acute inflammatory phase in 2 weeks. Now, an unhealthy 55-year-old with high systemic inflammation might not get to that other side till 6 weeks, meaning there could be sort of chronic inflammation that takes a long time to resolve. So it really depends on the person and when that acute inflammatory response is done. Brian, Dr. Centeno, I wonder how to do with anterior longitudinal articular. Not sure what that question means. Anterior longitudinal ligament or anterior articular capsule would have to be done from the front. So that would be that level 4 procedure, meaning it's highly technical. There's a lot of stuff in the way. For instance, the nerve that allows you to breathe, called the phrenic nerve, internal carotid artery that provides blood to your brain. Lots of important stuff to miss. Isabella, addition to my previous question, the technique that he used was neuroprolotherapy, so multiple injections, a lot of fluid at the base of the skull. Yeah, Isabella, let me go back up to your other question just so I can make sure I'm answering your question here. Apologize, got a lot of questions to scroll through here. Yeah, so that would be a blind technique. So I don't know how deep he went. One thing that would be relatively superficial that could be damaged if you didn't go too deep would be the occipital nerve. So again, I'd have to perform an exam and look at that in detail to try to answer that question. Finn, can going into extension cause C1 to slide anteriorly, or is it usually a phenomenon in maybe going into flexion? I think, Finn, is what you meant to write. So yes, that would be part of that same thing we talked about, meaning this past Friday, where the skull can slide forward in flexion or backwards relative to the atlas in extension. Arno, where's the book that you said describes how symptoms are caused by CCI? Where is that book? Let's see. Okay, so this is Centeno Schultz Clinic site, centenoschultz.com. I think we go over here to specialty areas. Then we go to upper cervical. Click on that. Let's just go to the overview. And then we'll scroll down from there. And it's at the very bottom here. So that URL would be centenoschultz.com/craniocervical instability / or I guess craniocervical instability CCI. So let me move that. Well, I don't think it's going to move. So let me just post. I tell you what, I'll just post the link down here, and then you can just click on the link, and then you want to go to the bottom of the page there in order to download that book that I talked about. So I just put that link down there so you don't have to try to remember all of that complex stuff. WWSoft, do any medical schools have programs specializing in ligaments? If not, do any schools more ligament aware than others? I know it really depends. Not really. That's something you're going to have to learn once you get out of medical school and once you get out of residency or fellowship through specific courses. A really good organization for that would be either AAOM, the American Association of Orthopedic Medicine, or IOF, the Interventional Orthobiologics Foundation. Those are two organizations that have a big ligament track and education. Manuela. Are there any blockers that can be done to confirm that Mount Bridge is the source of my pain? No, that's a hard one to block because we'd have to block the dura as well. And the pain is usually caused by the dural infolding. So if we were to put anesthetic in your dura, you'd stop breathing. So bad day for everybody. So no, can't really block that one. Isabella, what's the best to prevent the muscles and shoulders pulling on the upper neck? Do you recommend massage drilling or PRP in the muscles or a better approach? Generally treat the instability because that's generally an instability sign. Sometimes there can be irritation of the 11th cranial nerve as well, but it's usually treating the instability. Stace, I've reached out to Carla to schedule my next PSL health right after your summer vacay. Not asking for you to state your preference here, but because the reports are formatted very differently, would you have a preference as to whether you want to update DMX Dr. Postlewaite or Dr. Katz? I think Evan Katz would be great. He would be a good one. Finn, can the atlenostyloid or maybe the atlenodental interval decrease in extension, or is this more of a flexion thing? Wondering if interval extension is generally safe with humans elongated styloids. Increase in the cervical lordosis shouldn't be a problem with elongated styloids. Again, Finn, elongated styloids by themselves don't mean a lot. It just would be if there was a problem with instability, which can then make elongated styloids more of a thing. But ADI, or atlenodental interspace, I think that's what we're talking about here, but correct me if I'm wrong, would only be in flexion or an increase in that ADI. Rigolab, there's a recent study that nothing proves anything, but certainly that maybe suggests the concept of injectable mRNA that induces collagen gene expression at skin level, restoring skin tightness, could be adapted for future treatments. Injecting mRNA would be illegal since that would be an unapproved prescription drug. So no, I don't think that's possible. What was the website to find curve correction providers? Yeah, let me put that down here. Actually, I'll tell you what, let me pull it up. It's idealspine.com. Yeah, that's it. Okay, so I will post that down here as well. Idealspine.com is the website to find those providers. I don't know what that one means. Robert, have you done dextrose first to trigger inflammation, followed by sooner treatment of PRP, or vice versa, PRP first, then dextrose? The only protocol we have like that is for joints, but not for ligaments. S. Dennis, no questions to my side. Okay, great. Sounds good. Lexi, I have high pressure in head mostly when I stand and turn head, also dizziness and balance and brain fog, headaches. Noted. Seen all doctor, blood work plus MRI, all normal. Seen 3 chiropractor. Yeah, so that would generally mean that you would probably need movement-based imaging next to rule out that there's an issue there. There could be an issue with a bad facet joint, for example, etc. So all of those things wouldn't necessarily show up on that imaging. Let's say I have C2, 3, 4 instability, recommended dosage of each area. Not sure dosage of what it is we're talking about there. What do you treat muscles with, PRP or PPP? Robert, usually PPP. Okay. Listen, guys, we are an hour and 5 minutes now. So I think I've gotten to the vast majority of questions. What we were talking about today was the transverse occipital ligament, which is a band that runs across the bottom of the skull that prevents the dens from tipping backwards into the spinal cord. And it's one that really gets talked about. So we'll be talking about various things over the next few weeks here. But I'd like to bring up every once in a while one of these lesser known ligaments that just don't get a lot of coverage. People just don't talk about them. You hear a lot about alar transverse ligaments. You hear a lot about certain things, but transverse occipital ligament is not one that gets talked about, just like Barco's ligament doesn't get talked about, or the accessory ligament doesn't get talked about a lot. So I'd like to every once in a while bring up one of those ligaments to the group here. So again, thanks so much for watching today. I will be here. Oh wait, no, I won't be here this Friday. I've got a funeral to go to in Atlanta. So I won't be able to do this on Friday, but I will be here a week from today on Monday. So I look forward to seeing you then, and I want you to have a great week. Thanks for all the great questions. And remember, no such thing as a bad question here. It's all about questions and answers and learning. So thanks so much. Have a great week.